Hi, I am Manoj Padman, pediatric orthopedic surgeon from New Delhi. As part of IFIX 2020 web conference, I will be talking about lateral condyle fractures of the humerus in children, focusing on the management of fresh injuries. These are my affiliations and I do not have any disclosures. Before getting into the details about management, a brief overview. Lateral condyle humeral fractures are the second commonest of all pediatric elbow fractures, coming in after supracondylar fractures. The fracture involves the physis and extends into the joint. Though the capitulum itself is ossified, the fracture line goes through unossified cartilage of the distal humeral epiphysis. And sometimes it may be difficult to appreciate the true extent of the fracture as well as the displacement on plain radiographs. Poor outcomes are directly linked to displacement. Sometimes it is apparent on the injury films, or sometimes it occurs during the course of non-operative management as late displacement. Displacement leads to articular incongruity, and that has a direct link to poor outcomes. Late displacement is known to occur in 15% of cases treated non-operatively. Complications in some CDs have been reported to be as high as about 30 to 35%. Significant complications or serious complications which warrant reoperation are much lesser in incidence. What are the challenges that we face in the management of these injuries? First and foremost is getting an accurate and timely diagnosis. And second is the problems of evaluation, wherein one has to assess the stability of these fractures, especially identifying the potentially unstable fractures. I will be touching upon the principles governing non-operative and operative management during the course of this talk. With regard to timely diagnosis, there are two key things. One is a high index of suspicion. The clinical features are not as florid as one would see in a displaced supracondylar fracture. All the clinical signs are localized to the lateral aspect of the elbow, be it swelling, bruising, or tenderness. In terms of radiological evaluation, the standard anteroposterior and lateral views are not adequate. One needs the mandatory third view, which is the internal oblique view, to see the fracture in full profile and to understand the true extent of displacement. Here is a case in illustration. There's a seemingly innocuous injury, as you can see from the AP and lateral view. The telltale sign of swelling localized to the lateral aspect of the elbow. The surgeon chose to treat this non-operatively in plaster. 2.5 weeks down the line, when the plaster was removed and repeat x-rays were done out of plaster, clearly it's a displaced fracture which warrants surgical intervention. So one should have picked this up earlier to avoid this complication. In terms of evaluation, I'm going to take you through a sequence of events to assess the severity of injury. That's the objective. And our classification systems should help us in identifying the severity of injury as well as to guide you through a course of treatment. Historically, the anatomical classification Milch, which has been used for a long time, the problems of Milch classification were that it did not predict a certain course of treatment. It did not guide you into formulating a course of treatment. Also, it was found that there was poor correlation between the preoperative radiological X-rays and the Milch type with the actual intraoperative findings. Salter-Harris classification was never popular for lateral condylar fractures. Attempts were made to kind of predict the stability of fracture, and the classifications which became much more popular were Jacobs classification, looking at the integrity of the articular surface, and that's still continuing to be used. Finn Bogazan looked at minimally displaced fractures and using the fracture gap medially and laterally made predictions about unstable and stable fractures. Of late, in the last 10 to 12 years, classifications of Song and Weiss, which have looked at the integrity of the articular surface as well as the degree of displacement, have been useful in formulating a form of treatment, either closed or open reduction, depending on the degree of displacement. So there's no confusion at the milder end of the spectrum. An incomplete fracture, which is confined to the metaphysis, is clearly a stable injury and ideally suited for non-operative management. Equally, at the other end of the spectrum, wherein fractures which are displaced, there is displacement, there is split, there is a tilt or a rotated fragment or associated with a fracture dislocation. All of them are clearly unstable injury patterns and need operative management, be it closed or open reduction. The problem is that there is a huge spectrum of cases which lie in between in the so-called gray area. seemingly undisplaced or minimally displaced fracture, as you can see in this particular illustration. So what are we trying to achieve by evaluating? What are we trying to find out? We're trying to identify precisely what is a displacement, are trying to understand whether all minimally displaced fractures, are they all identical? Is displacement of a fracture, which is a static phenomenon, the same as instability, which is a dynamic phenomenon? Can we use displacement at the metaphysis, which is where we usually measure it, as a predictor of articular integrity? So I'll try to address these one by one. What constitutes displacement? Displacement is usually classified as less than 2 millimeter or more than 2 millimeter. It's measured on any of the three views and is often best appreciated on the internal oblique view because the AP and the lateral tends to underestimate it. Is it the same as instability? Can we use the existing classifications to predict stability of a fracture? Jacob's work was on cadaveric studies where increasing forces applied to the pediatric elbow caused increasing displacement and progressively disrupted the articular hinge. As the grade of displacement increased, these tended to be more unstable, and the type 3 were displaced and rotated fractures. Finn-Bagasan looked at the other end of the spectrum, the minimally displaced fracture, and using the fracture gap on plain X-rays to see whether the medial and the lateral fracture gap, the lateral fracture gap being at the metaphyseal side and the medial gap at where the metaphysis ends and the epiphysis starts, to see whether they were symmetrical. Incomplete fractures were confined only to the metaphysis. The type B, they had an asymmetric fracture gap. The lateral gap was much more open. The more worrying fracture is the potentially unstable complete fracture where the fracture gap was even both medially and laterally. As you can see from this illustration, this is a Finn-Bagasan type C, where the fracture line is parallel. The two gaps, the lateral gap and the medial gap, are equal. These were classified as unstable injuries because they were complete fractures or potentially unstable fractures, to be more precise. Song in 2008 published this landmark article in the American Journal, which looked at initial segregation based on the degree of displacement. The transitional gap was a Finn-Bagasan type C with equal fracture gap. The higher grades were unstable, which clearly warranted stabilization. Can you use displacement of the metaphysis, which is where we measure it, as a predictor of articular integrity? And this was attempted by David Skagg's group. Weiss et al. Published it in the JPO in 2009. The type 2s and type 3s were displacement with displacements more than 2 millimeter. Using an arthrogram intraoperatively, they looked at the articular hinge. Those in which there were more, the articular hinge was disrupted. The authors treated them operatively with open reduction and fixation. Intact articular hinge, where fractures with intact articular hinge were treated with close reduction. As you can see, at the end of our evaluation with X-rays, this is the information that we are looking at. We are looking at the degree of displacement. Clearly, the ones which are above 2 millimeter were grouped as displaced and unstable. Those less than 2 millimeter, you had the incomplete fracture, and the indeterminate one, wherein there was asymmetric fracture gap. Those could be treated non-operatively. Where those fractures which had equal medial and lateral gap were potentially unstable and warranted early fixation. So this is an incomplete fracture. The fracture line is confined to the metaphysis, ideally suited for non-operative management. And what do we mean by non-operative management? An above elbow cast with the elbow flexed to 90, forearm insupinated with the wrist extended to relax the extensor muscle mass. The key in any non-operative management is follow-up with weekly X-rays, because most of the displacement happens within the first 7 to 10 days when the swelling goes down. The other key factor is that the cast should be continued till there is radiological evidence of union at the metaphyseal site. Here is an illustrative case. This is a minimally displaced fracture, a Jacob 1 or a Song 2, because the fracture gap was not parallel. Surgeon chose to treat it conservatively. Follow-up X-rays at 1 week, taken out of plaster. There should be no hesitation in removing the plaster to get adequate views to confirm that the fracture is not displaced. At 2.5 weeks, further follow-up X-rays in plaster confirming that there's been no further displacement, and this went on to unite without any complications. When do we go in for operative management? Reduction and stabilization is indicated for those displaced fractures with articular malalignment and potentially unstable fractures. And we do this by the closed or open reduction and stabilize with KYs or screws as appropriate. A few principles about closed reduction. Closed reduction is done with the elbow extended. A varus stress is applied to the elbow so that the lateral gap is opened up and the fragment can be slotted back in. Direct pressure on the fragment helps to key the fragment back in and to prevent proximal migration. KY joystick can be done as an adjunct. The other crucial aspect of all closed reduction is that the articular surface has to be evaluated, and that can be done only with an arthrogram. And that's mandatory. Once again, stabilization and cast, whether it's stabilized with wires and cast, they should be retained until there is evidence of union. So here is a fracture which is displaced, seemingly displaced about 2 millimeters, so therefore would come into the song 3. The internal oblique view does not show any further displacement, but the fracture gap, as you can see, is parallel on the internal oblique view, and therefore this would be a song 3 which is potentially unstable, chosen to be treated with closed reduction and percutaneous fixation. The articular surface has to be evaluated with an arthrogram. As you can see, it's congruous, there is no step, stabilized with 2 divergent wires. This is a higher grade injury, which is a song 4 because the displacement is more than 2 millimeters, a Jacob 2 because displacement is there, but the fragment is not rotated. This can be treated either by closed or open reduction, but definitely warrants stabilization. Those are the X-rays in plaster. As you can see, the top left picture with a little bit of varus stress and direct pressure on the fragment, you can see that the gap is reduced, but one needs to confirm that it is true reduction of the articular surface, and that can be done only with an arthrogram. Once that is established, it is treated with percutaneous KY fixation rather than an open reduction. One could criticize these 2 wires being too parallel. The ideal configuration should be divergent wires with at least a 60-degree spread. Occasionally, a third wire or the second wire could be inserted more horizontally, bearing in mind that it is passing through unossified cartilage and the hold itself may not be as strong as it is through bone. Also, the lower 2 wires coming out at the medial epicondyle are in close proximity to the ulnar nerve, so you should not leave them proud at the opposite, at the far end. This went on to heal unevenly with the lateral spur, which is a cosmetic problem without any functional issues. A higher grade fracture, which is much more displaced than compared to the previous X-rays. There is much more opening up on the lateral side, but the fragment is not rotated. So this would be a song 4, but certainly getting into the grade of Jacob 3. Can be treated either by closed or open reduction. A reduction maneuver with simple manipulation, you could close the gap, and so therefore an additional maneuver is done with a joystick to close the gap, and the articular surface is evaluated with arthrogram. The middle picture clearly illustrates where the landmarks are, the yellow circle being the capitulum, the blue dotted line being the fracture line, and the red is the intact articular surface. Stabilized with well-spread KYs, the bottom wire running more horizontally and through unossified cartilage. Went on to heal unevenly with the lateral spur. There is a subsequent talk on complications of lateral condyle fractures. Lateral spur is almost universally seen even in non-operative fractures. They are a cosmetic concern because of the prominence, but do not cause any functional impairment. And so they do not end up as listed as significant complications. So this is a different fracture in the sense it's an older child, a Jacob 2, a song 4, but with a large metaphyseal fragment. Again, with direct pressure and a little bit of varus stress, you can see that the fragment is slotted back in. It looks well reduced, but it needs to be confirmed with arthrogram. A provisional fixation was done so that the fragment would not move. Arthrogram was done to evaluate the joint surface. Because of the large metaphyseal fragment in the older child, this was fixed with percutaneous screw fixation, cancellous cannulated screw, partially threaded. And at follow-up at about 2.5 months down the line, you can see that there is callus at the metaphyseal end, although the fracture has still not united. A brief few words on arthrogram. This can be done either through the posterior, through the triceps, into the just superior to the olecranon into the joint, or through the lateral soft spot, the classical site for aspiration of the elbow. My preference is, and the convention is that use the posterior approach because any leakage of dye on the lateral side from a lateral approach obscures the outline of the fracture and the lateral condylar mass. You do not need a large volume, barely 2 to 3 ml of diluted dye is adequate. In terms of fixation, KYs are much more preferred, but they should be left out. There is a publication confirming that wires left out tend to have lesser complications than buried wires. Screw can be inserted with or without washer, cannulated screws. The lateral condyle mass is only of sufficient size to accommodate a single screw, can be supplemented with an additional wire. Ideally, it should be through the metaphysis with a large where there is a large metaphyseal fragment. Although screws running across the physis have not been shown to cause any problems, any complications related to growth arrest or deformity. There's been one reported study about better outcomes with screws when compared to KYs. But all screws would need secondary surgery for removal almost inevitably 6 months down the line. With regard to open reduction, the principles are it's a lateral approach or a slight anterolateral approach. The plane of dissection is created by the fracture displacement. The dissection is confined to only the anterior side, and that's used to visualize the articular congruity. One avoids any dissection on the posterolateral side because of the tenuous blood supply which comes from that side to minimize avascular necrosis. Stabilization and cast is kept until there is evidence of union, as is the case with all lateral condyle fractures treated. Here is a case which is a rotated fracture, Jacob 3, Song 5, not reducible by closed means, open reduction done and well fixed with divergent KYs. Went on to unite uneventfully at 18 months follow-up, had full functionality regained as well as complete radiological union with no complications. So if you look at the slide which I had put up at the end of our evaluation, this is where we would end up. Those which are minimally displaced but potentially unstable with equal medial and lateral fracture gap, one would strongly advocate that they would need to be fixed. They do not need a formal open reduction and can be fixed percutaneously with wires or with a screw. But an arthrogram is a must in these fractures. Those which are displaced, which come into the more than 2 millimeters displacement, if the displacement is less than 4 millimeter, the assumption is that the articular surface is intact, which can be confirmed with an arthrogram, and they are amenable for close reduction and fixation. However, if one is not familiar with the technique of reduction or with arthrogram or the interpretation of an arthrogram, there is no harm in achieving articular congruity by directly seeing it through a formal open reduction. That remains the gold standard. Whereas those which are displaced more than 4 millimeter, the assumption is that the articular surface is disrupted, and so they are better dealt with open reduction. The surgeons have started to extend the indications of close reduction and with adjunct maneuvers using joystick. But if one is doing close reduction, an arthrogram is a must to evaluate the articular surface in these situations. What are the areas of controversy? We need to be able to identify the potentially unstable fractures better, earlier, so that we can preempt any late displacement. Whether it requires additional imaging like an MRI, ultrasound, or a CT scan is not yet evident. Currently, we are relying on plain radiographs and the fracture gap medially and laterally to kind of identify. In terms of the other area of controversies, what is the limit of a successful close reduction? Can we use close reduction as the method of choice for greater displacement, where there is displacement more than 4 millimeter and rotated fragments? One has to bear in mind that by doing so, we have to balance the risk of a articular malunion, even though the articular surface is visualized by an arthrogram, the risk of potentially creating a subtle articular malunion versus slightly higher complications when we open up the fracture and see it directly. In conclusion, the take-home message is that in terms of evaluation, the third view, the internal oblique X-ray, is mandatory for all lateral condyle fractures. Non-operatively treated fractures based post-evaluation should be watched closely with serial X-rays for the first 2 weeks. Displaced fractures, there's no doubt, the key to that is articular congruity should be regained. If that means opening up the fracture, so be it. But if close reduction is being attempted, then it has to be evaluated by an arthrogram. Removal of cast and wire is only after radiological union. Many of us have seen premature removal causing late displacement. Thank you for your attention.